This is a complex case of a post-Whipple pseudoaneurysm bleed of the IPDA in a patient with significant cardiac risk of ischemic heart disease and PCI is on antiplatelets. The life-threatening hemorrhage was successfully managed via a minimally invasive endovascular approach, leading to a rapid recovery and discharge. A 66-year-old male known case of ischemic heart disease with a history of percutaneous coronary intervention for which he was on dual antiplatelet therapy. Presented with upper GI bleed. Bleeding duodenal tumor, ulcerated mass identified at the start of D2 on EGD. His CT scan reported a large 76 by 61 by 74 mm soft tissue heterogeneous mass, containing internal areas of necrosis arising from the second part of the duodenum, abutting the head of the pancreas, but the fat planes between them were intact. The portal vein was clear of mass. Major vessels were not involved. The pancreas itself appeared normal. There was no dilation of the pancreatic duct or the bile ducts. Case was discussed in MDT and Whipple's pancreaticoduodenectomy was performed. This is a video after dissection of our Whipple specimen. Here we can appreciate IVC, SMV, splenic vein draining in SMV and both continuing as portal vein. Behind these structures we can appreciate the aorta and SMA. SMA here giving an accessory right hepatic artery. Next we have here pancreas divided from neck and a feeding tube inside the pancreatic duct. Over the superior border of pancreas this is ligated GDA coming from common hepatic artery. CHA continues as proper hepatic artery towards liver. Proper hepatic is giving off right hepatic and left hepatic arteries. And in the end, we have this transected portion of CBD, secured with hemolock to avoid spillage. Histopathology showed a 7 cm gastrointestinal stromal tumor of second part of the duodenum. All margins clear of tumor. 1 out of 38 lymph nodes were positive. His antiplatelet therapy was resumed on post-op day 3 as a single agent. And he was discharged on 5th post-operative day. But on 12th post-operative day he presented to the emergency room with acute episodes of hematemesis. The patient was in shock and was resuscitated with IV fluids and blood transfusions. HB rose to 8.3 gram per deciliter after 3 transfusions. EGD was initially considered but deferred in favor of immediate cross-sectional imaging due to the high suspicion of a vascular complication. Contrast CT identified a visceral artery aneurysm involving the inferior pancreaticoduodenal artery. Interventional radiology consulted for urgent management. The patient underwent successful endovascular coiling of the IPDA aneurysm with cessation of bleeding. Here you can appreciate the coil across the aneurysm, and after successful deployment of coil, bleeding completely stopped. Patient then transferred to the ICU for next 48 hours for hemodynamic monitoring, where serial CBC were performed to ensure hemoglobin stability. The remaining hospital course was uneventful. The patient was successfully discharged on the 4th day following the IR intervention. Let's have a brief look at literature review on this subject. Post-pancreatectomy hemorrhage carries high mortality of about 40 to 58%. GDA pseudoaneurysm bleed counts for up to 3.9%, whereas IPDA pseudoaneurysm bleed is extremely rare. Interventional radiology is best management option to deal with IPDA bleed. Inflammation, pancreatic fistula, or abscess can erode nearby arteries and produce pseudoaneurysm or arterial wall injury. This explains why delayed bleeding frequently occurs days to weeks after surgery, often around the 2nd to 3rd postoperative week, and why sentinel bleeding should trigger urgent evaluation. For suspected IPDA or other arterial bleeding after Whipple, CT angiography and diagnostic angiography are key tests. In the systematic review of delayed post-pancreatectomy hemorrhage, interventional radiology was associated with lower mortality than reliparotomy, 16% versus 37%. Practical approach for an IPDA bleed after Whipple is resuscitation and correction of shock and coagulopathy. Immediate CT angiography if the patient is stable enough. Prompt catheter angiography with coil embolization or other embolic technique if the IPDA is the culprit. Surgery if embolization fails, the patient is unstable, or there is an associated intra-abdominal catastrophe.